Yes, I'm Dr. Louise O'Donnell, and it's my privilege to talk with you today about some myths and some truths about children's behavior. And I'm drawing on over 40 years of working with children and families. And the myths that I talk about are the things that I've heard when parents and families come to see me. These are the issues that they struggle with. And these are the things that they have to overcome before they actually come to my office. Now, I am a psychologist, but I'm also a pediatric neuropsychologist, and I do assessment work with children with various neurodevelopmental difficulties like ADHD, autism, as well as emotional disorders like depression and anxiety. Okay, so in this next slide, I I put together just some general myths, and you may have heard some of these things. Number one, and I hear it over and over again, is your child will grow out of it. It's just a stage, like the terrible twos. You may hear this from your pediatrician. You may hear it from family members. Now, I'm going to go over these myths right now on this list, but then we'll go back and talk about each one more in depth. The other one, the second one surprised me, but more than one person has said, I don't understand. This behavior does not happen in good families. Um, that, and the next one is if you just disciplined your child, everything would be fine. Parents tell me that's what they hear when their child acts up at a birthday party, at a family gathering, etc. Seeking help is a sign of weakness. I think that's pretty pervasive in our culture about seeking help for not only behavioral problems, but emotional problems as well. And if you see a psychiatrist or a psychologist, it means that perhaps that person or you are crazy. And I put crazy in quotes. And the last two have to do with medication. And parents are afraid sometimes. Medication will change my child's personality. He'll be like a zombie. That's one side of the coin. The other side of the coin is kind of a belief that pills will fix everything. And as you might imagine, both of those are myths. Okay, so let me go on and talk a little bit about your child to grow out of it. The underlying assumption is that the behavior that you're seeing or the lack of a behavior, let's say not walking, not talking, not making eye contact, it's part of a developmental process. And if left untreated, it will resolve on its own. Now, for many things, and in psychology and behavioral science, the answer is it depends. It's not always as clear cut. And so, for that, let's think about what is the actual behavior? Is it a delay in speaking or saying single words or saying sentences? And how much time has passed? Is the child or the toddler not talking at 12 months? Or is the toddler not talking? The toddler now is at 3 or 4. They're out of the toddler years. So so how much time has passed certainly frames that question and the answer of it depends. Um, you know, and so part of what I'm leading up to is the child will grow out of it. This is the acquisition of developmental milestones. And that's nothing more than when did they crawl, walk, though not every child crawls, and that's not necessarily indicative of difficulties. Saying single words, speaking in sentences. And one of the things I say to parents all the time, and certainly to my medical students when I teach them, is there is certainly a wide range of normal. If you're a parent and you have more than one child or you're around kids, you'll notice sometimes that some kids are walking at 9 months. Some girls may even walk earlier at 6 months. Girls oftentimes talk and walk earlier than boys. But the typical range, and you'll note it's a big time span, is between 9 months and 18 months of age. And most kids say single words by 12 months and speak in simple sentences by 24 months. And the red flags occur when the child is 3 years of age and barely speaking. The child at that point needs intervention. And one of the things I would definitely stress is trust yourself as a parent. And I'm going to say that over and over and over again. Nobody knows your child as well as you do. If you are worried, start with a consultation with your pediatrician. I know pediatricians are busy, but I think it's important for your doctor to talk routinely with you about your child's progress. Some pediatricians have a developmental checklist that you fill out, and you can kind of see what your baby's doing and what your baby has yet to acquire. And these are very quick things done in the pediatrician's office. I also listed a resource, and I think it's an absolutely excellent resource. And that picture's kind of blurred, but because I don't want you just to focus on that particular one. It starts, at 1 month of age on up, I think to 3 or 4. And it's part of the Centers for Disease Control part, and it involves, it's a website, cdc.gov, act early. And on the sheet, and it lists what, for example, for 4 months, what socially, emotionally do they do? What kinds of language skills are occurring? What cognitive things? That's by cognitive, we mean learning, thinking, problem solving, and movement. And the second part of this, which I think is so very helpful, is what can you do for your child to stimulate it? For example, hold and talk to your baby, smile and be cheerful. That increases social emotional connectiveness. You help the child by having steady routines for sleeping and feeding, though I know that many children kind of buck that, but the more often the child can, if the child can get into a regular sleep and a regular feeding session, they will be happier, and so will you as a parent. Um, so those kinds of materials, I think, are very helpful in answering the question, where is my child? Is this a delay, or is this within the wide range of normal? The other thing that I found on this website is there you can download an app onto your phone, which gives you a little tracker where you can check off and say, "Oop, they did that, X, Y, and Z." And so you can know how your baby's doing it, and it keeps track for you. And I think that is very helpful. So, as part of answering the question, your child will grow out of it. I raise this one for social emotional connectiveness. And by that, I mean eye contact. Responding to their name when they're a toddler, and understanding pointing or joint attention. Not doing those activities is a cause for concern and needs further investigation or intervention. Not being responsive to their name, well, let's first figure out if do they have chronic ear infections. Having ear infections when you're a toddler impacts certainly hearing, but it also impacts language. And that's why it's so incredibly critical to be aware of your child's health. And sometimes kiddos do not let you know when they have ear problems. So they may just pull on their ear or they may just be fussy. So if the child is not responding to their name, it's not necessarily something that is cause for concern with intervention, as in potential autism spectrum difficulties. It may be as simple as getting their ear infection treated. However, the eye contact and understanding when you point or understanding gestures, those, if the child has difficulties with that around 24 months, the research has shown that those children oftentimes go on to have developmental delays and or they have mild autism spectrum difficulties. So those are red flags, and just know that it is possible to diagnose autism at a young age, at age 2 and 3 years. And I'll talk, and there are some very good reasons for intervening early. Okay, the other thing is it something that the child will grow out of it? Well, with executive functioning, that's real. Executive functioning means really how do they handle frustration? How do they sit still and focus and attend? How do they adjust to change? And in general, our behavioral expectations increase as kids get older. And what happens with kids that have delays is their cognitive intelligence may be on track, but their frustration tolerance, their temper tantrums, they are still functioning like a much younger child. So there's a disconnect there. Now, we do expect temper tantrums with young kids when they're frustrated. That doesn't mean they can't learn. They can't learn to use their words rather than biting or hitting. And what we expect of an 18-month-old is very different from what we expect by the time the kids get to kindergarten. Kindergarten has a lot of executive function expectations. The child has to take turns, sit in a circle, focus, listen, and some children are not mature enough for kindergarten. But with appropriate intervention, kiddos learn and catch up. Now, there are reasons for delay beyond these typical timelines. And being born premature certainly kind of kicks everything back. And so when doctors and when parents are looking at, well, is my child on time? Do it based on when the child was supposed to be born. So you will not, if the child is 2 months early, then you take that into account as you're looking at the charts. And also if the child is part of a multiple birth, most times kids are delayed. If there's a family history of delay, language disorder, for example, a lot of these conditions have some genetic component to it. Or the delay, for example, in executive functioning is part of an attention deficit hyperactivity disorder. Okay. And here's an illustration also where separation anxiety is typical and it is a normal stage. Babies recognize their parents, and when the parent is gone, they don't have a time sense, and they don't know if the parent will be back, and that causes anxiety. Then kids get uh, object permanence. They understand that the concept of parent occurs even when the parent is in the other room, and their anxiety disappears, as opposed to this becomes something that needs to be intervened with if the child has a separation anxiety disorder. They have excessive fear and anxiety when separated from their parents. And I've had something like 5 children who had severe separation anxiety, and they also had selective mutism. They were so um, anxious and unable to speak that they just stopped talking in class, and they stopped talking to peers, etc. And they required therapy and intervention. Okay. So to back up with this, the problem with this belief, when there really is a delay or difference, is the child probably will not grow out of it on their own, and the child's going to continue to struggle and fall further behind. And the family, they're losing valuable intervention time. And research has shown that early intervention works. And in the schools, they have wonderful ECI programs, early childhood intervention programs, Head Start, PPCD. Those are available to parents and get the kiddos the speech and occupational therapy and physical therapy that they may need. And occupational therapy can help with tying your shoes, holding a pencil, because the kids have to know how to manipulate those kinds of things, and it is very frustrating in class if the child does not have a very good pencil grip, etc. So all of those kinds of therapy services are important, and speech therapy, it is almost twofold. It helps with certainly articulation disorders, stuttering, but a speech therapist also works on teaching communication skills, asking questions, doing reciprocal conversation. That is, having a back and forth conversation. So there's an awful lot of teaching and practice that goes on. And the wonderful thing about early intervention services is these therapists want to have their services generalized, so they welcome family input. Because if you think about it, the therapist is only spending and maybe an hour a week or 2 hours a week, yet the parent is with the child, during waking hours. And so there are lots of strategies and parental um, uh, you know techniques that parents can learn to maximize. And I'm not suggesting that you be a mini therapist. What I'm suggesting is there are a lot of what we call teachable moments. When your child talks, you interact back, you work on eye contact, and it is very ecologically valid. It's natural. It occurs in the home. And that's really what the purpose of all of this, because the child then gets a chance to practice and learn the skills, because that's another assumption inherent in all of these interventions. These are skills that children can learn, and they just need practice with them. Okay, so I've kind of gone over, let me go back, the growing out of it. And again, it depends. Some children do grow out of it. Some children do not and need intervention. And as I say, you know your child better than anyone else. And if you believe your child is delayed, then talk to someone about it. This behavior does not happen in good families. The underlying assumption with that is that if a behavior is occurring, a meltdown, it's somebody's fault. And, I, I, I just honestly believe we've got to move beyond blame, because, you know, yes, a lot of behavior disorders, certainly dyslexia, ADHD, for example, neurodevelopmental disorders, they do have a genetic component, but we really, that really doesn't help us um, work with the problem. It doesn't help us figure out a way to help the child. And I want to, with all my families that come to see me, it's not about blame. It's about what does the child need and how can we help them um, get the services they need. But just towards general education, whether it's a good or a bad family, I don't even like those terms. But let me just say, neurodevelopmental and mental disorders are very common. And I've thrown some figures up here. Anxiety and depression with children, 3 to 7, that's approximately 4.4 million children struggle with anxiety. And there are techniques, there's lots of wonderful intervention techniques to reduce anxiety. And 3.2% of school-aged children struggle with depression. And again, that's 1.9 million. And with adults, um, for example, adult depression is very common as well. So it's not a question of good or bad at all. And I just want to talk a moment about ADHD. Just some facts. It's the most common mental health disorder in children. It affects 4 to 12% of school-age kiddos. Boys are diagnosed 3 to 4 times more, but girls are less likely to be diagnosed because they oftentimes have the ADHD inattentive type. These are the girls that are not a behavior problem. They're sitting quietly in class, but they're distracted and they're struggling. And there's oftentimes with girls a very high co-occurrence between ADHD inattentive type and anxiety disorders. So that in clinics, however, the boys outnumber the girls. But when we do community samples, they're roughly the same. And ADHD affects, preschool age children and adolescent kids as well. Though over time, ADHD, the combined type, oftentimes lessens, though the inattentive component remains. You walk out the door and you've forgotten your keys, for example. That's inattention. And certainly those executive functioning skills, the planning, organizing, problem solving, there are many, many strategies that we can use and people that have ADHD very successfully use. But it requires being diagnosed correctly. Okay. So this next one, if you just disciplined your child, everything would be fine. I've often, when I've dug a little deeper with that, the buzzword is discipline means spanking. If you just got them in line. And imagine hearing that from well-meaning relatives. The parents are frustrated because obviously the spanking or whatever they've been doing has not corrected the problem, and they feel judged negatively and feel like they're not being good parents, when in fact just the opposite. They are trying very hard to figure out what works. So, to start to tease that apart, I want to say that, you know, it's and also in schools with teachers too, and um, just all behavior occurs for a reason. The behavior might be socially inappropriate, but it's meeting an emotional need. That's one thing. It doesn't occur in isolation. There are antecedents or triggers. There's the behavior and then consequences, kind of the ABCs of behavior. And within the T-Chat program, we have therapists who can work with parents on these types of behavioral issues. And so I'm not going to go into great detail, but I'll give you kind of an overview. Um, so what do we mean by challenging behavior? It's always good to, when a parent tells me that, I want to know if they say the child is behaving badly. Some parents think behaving badly is when the child, stomps their foot or clenches their fist, versus a child who throws something or punches walls. You see the difference there. So behavior that is explosive, and I've listed some things: temper tantrum, hitting, destruction. That's verbally, that can be verbal abuse as well. And then that's kind of impulses outward. And then there's behavior that involves avoidance or withdrawal or a refusal to interact. And so with the first one, an intervention would be, we want to reduce the explosive behavior that involves withdrawal. We want to increase a new learned behavior in both of those. And then there's behavior that is repetitious and inflexible. And I'm kind of hinting at children who are on the autism spectrum oftentimes take comfort from the ritual, and it helps them control and reduce their anxiety. And any changes in their environment is very upsetting, because they don't feel able to predict and control their environment, especially if the child has autism and has some right hemisphere difficulties with understanding gestures, verbal expressions, all and the nonverbals. The world is can be very confusing. Okay, so why is it important to find out why the behavior is occurring? Well, because sometimes I think the assumption people have is that child is just a bad kiddo, or some other negative word. So if you stop and think about why is it occurring, it helps you understand the purpose or the need, and then hopefully we can intervene more effectively. I know parents do this all the time. They understand, well, this child is grumpy. They need a nap. This, or, they understand what triggers are. But some kids are not very good at putting out signals. So, the parents have to work harder. But if we don't understand why a child is doing something, and sometimes there is parental mismatch, the child is very reactive and the parent is reactive, then parents end up in power struggles, and in a power struggle nobody wins. So if one of the first steps in working with parents is to help everybody kind of understand, including the child, why is this behavior happening? What's going on? And that's the intervention that the T-Chat therapists work with: reduction of the behavior that's not effective, and introducing new and successful behavior that's more adaptive, because that's the bottom line. We want the child to interact better and be more successful. And sometimes, if interventions are just punitive, we forget the second part of the equation. If it's just time out, um, it's time out, and then what do you need to do differently? Um, so we don't end up back in time out. So I think it's important to think about both of those. And the other thing is, not kids don't do, kids are complicated. People are complicated. Not all behavior has the same motivation. And I just threw some of these things up there. Acting up in class clown. Well, why? Well, do they have a math deficit? Do they have dyslexia? They would rather be yelled at than being humiliated by not having their weaknesses displayed to the group. Or is it control? And they may be more than one thing: to gain attention and then control the situation. You can't make me do something. And kids that are oppositional defiant, that's kind of their default mode. So in working with them, you have to kind of get out of this um, control situation into, this is, you are in control, but here are the choices. But you, as the therapist parent, give the choices. Communication problems, that's kind of the withdrawal, wanting to be accepted, etc. So there are all different motivations. So it requires, I think, an understanding of all of those things when we're looking at finding something that works. Okay, so to shift a little bit, so coming in and saying, okay, I think some things are going on with my child. Oh, what does that mean? Oh, am I a bad parent? I've had parents cry because they feel ashamed and they're doubting themselves. And sometimes when I give a diagnosis, the tears are, in a way, it's sadness, but also relief. Now I know what's going on, and we have a plan of action. And I think sometimes parents delay getting help if there are all these pressured things on them. They may say, no, I don't want to be crazy. I'm doubting myself. But inside they know something is still wrong. And the whole bottom line for me with this, it really is unnecessary emotional burden on families and on kids. And there are lots and lots of resources out there. We just need to make it accessible for parents in an open environment where people can say, yeah, I have a problem. I need help. And and as assessment professionals and treatment professionals, one of the things we must do is remove judgmental attitude. We do not know the child as well as the parents do. And just as an aside, yeah, I tell parents there are no perfect parents. And if somebody is portraying themselves to you as they're lying. Because being a parent is hard work. And do we always, and I'm a parent and a grandparent, do we always get it right? No, but we're in there trying. And it's not an all or nothing thing. That's just like with learning new skills. I think parenting is a skill as well. Okay, now I've talked about some of the assessment components, some of the behavioral interventions, and I'm just going to briefly mention the medication component. And Rena Pardawala may talk about that more, but most likely in context of the T-chat. So, as I mentioned, kind of the medication kind of being put off by it versus the pills fix everything. Certainly, in my experience, in working with children that have ADHD, I have to say appropriate medication. And by appropriate medication, I mean medication that is prescribed by someone that the family trusts and listens to them and just doesn't dose and adios. And I know that sounds maybe trite, but if the child is placed on, let's say, stimulant medication, checking in with the family to see how they're doing, checking in with teachers, finding out if if there are any side effects. But in general, it this medication will not change your child's personality. All it does is help the child focus and sustain attention for short periods of time, really. You can have an extended release pill during the day to help you focus for school. And because of the increased ability to focus, the child can take better advantage of instruction and intervention. Because I know children who are sitting there trying to pay attention, we put them in scanners. They are actually utilizing more parts of their brain than just the prefrontal cortex. It takes them more energy to focus. And when a child has to do that, they don't have enough energy and attention and bandwidth really to absorb the intervention or the instruction. So it's almost like they're having to fight that. And it worries me when people think they're not working hard enough. That's not true. They're really working hard. They're working harder than everybody else. They're just less efficient at it. And over time, kids get more efficient as the brain improves or myelinates. But the fact of the matter is, at that point in time, that child is having to work harder. And what medication does not do, it does not change your child's basic personality, and it doesn't automatically translate into better executive function skills like being better organized. Those are skills that you teach. Those are kind of the top-down skills. The medication helps with regulation, but the higher functioning stuff and the academic skills, you have to learn that. And I'll share with you a quick story. My son, well, I have twins. One of my sons has ADHD, and we made a very difficult decision to place him on medication. And he asked me, okay, will it do my work for me? Will it do my homework for me? And I said, no, you're going to have to do the work. It'll just make it easier for you to do so. And it did. So that really kind of concludes the presentation on MISS. And at this point, I will turn it over to people and to Rena to talk about the T-chat. And then I believe after that, we're going to take questions. Thank you for your time. And here's Rena.
Thanks, Dr. O'Donnell. Can everyone hear me?
Yes, we can, Miss Rena.
Okay, perfect. Okay, let me share my screen. All right. So my name is Rena Pardawala, and I'm the clinical coordinator for T-chat. And I'm also a physician assistant, and I provide medication management for TChat. So, what TChat is, it's a state funded program um, that provides free mental and behavioral health care services for students and their families within our partnering school districts. So, TChat stands for Texas Child Health Access through Telemedicine, and it's through UT Health San Antonio in the Department of Psychiatry and Behavioral Sciences. So, TChat is transforming access to mental and behavioral healthcare services for children and their families by connecting students with rapid access to services through telemedicine. So, all of our visits that we provide are telemedicine visits, so they're virtual over Zoom. And the services we provide include medication management and psychotherapy and counseling and also life coaching. And the goal of TChat is to really connect people to mental health care quickly, because one of the big things that we notice, especially in the city of San Antonio, is it's very difficult to get in to see a provider in psychiatry or behavioral health because of wait times, and it's usually months of waiting. And so, what we want to do is we want to provide access quickly so people can get seen sooner than later.
I'm sorry, Miss
So,
Rena, for the interruption, but I don't see your PowerPoint.
oh, is it? Oh my goodness. Okay. Let's see here. Are you able to see it yet? Can you see it now?
No, I'm sorry, I can't see it now.
Okay, hold on just a second.
Now I see it, Miss Rena.
You see it, and you can see it as a full screen, or are you seeing like the two screens?
I see the two side, the next slide, and there I see all your presentation.
Okay, let's see here. Hmm.
So if you click slideshow and then put current slide, you should be able to show the whole screen. There you go, perfect.
There we go. Okay, perfect. Okay, sorry about that. So let me just go back here. So TChat, it's TCHATT, Texas Child Health Access through Telemedicine. And the services we provide include medication management and psychotherapy, counseling, and life coaching. And the services we provide are for students of any age from any income background within our partnering school districts. So that includes our current partnering school districts, including San Antonio ISD, include Harlandale, North ISD, Northeast ISD, San Antonio, and South San Antonio. And a few more will be coming soon, and we hope to continue to expand. So, TChat is a free service for students and their families. So, what that means is all children have psychotherapy, medication management, counseling services. They're all for free. And family members, including parents of the participating student, can also receive free supportive counseling services, um, which is one of the beautiful benefits about TChat. Our goal is really to provide wraparound care for children and their families, because we all know that children do not exist as an island, and that often environments are affect a child's behaviors. So at TChat, we manage a wide variety of conditions, including depression and anger management, anxiety, um, suicidal thoughts, or self harming. Pretty much anything that you would generally send to a psychiatrist or a counseling provider, we will manage those conditions. What we don't provide is emergent mental health services, meaning that a child is an imminent risk to themselves or others, meaning they're suicidal or they're homicidal. In those kind of situations, you'd want to take your child to your nearest emergency department or to a psychiatric department. We also don't provide psychological testing, disability evaluations, or long term treatment or therapy. So, this program is really meant for short term therapy and short term treatment. Our goal is to stabilize the child from whatever current situation they're in, and then for them to be able to continue with their with the provider in their community or their pediatrician. For instance, if we started a child on ADHD medication, then we could stabilize them on their medication and then send them back to their pediatrician to continue their medication management. And we would also be able to help the pediatrician manage their medication if they needed help with that. So we really want to target um, kids that don't already have behavioral providers or mental health providers. Um, our goal is really to assist with caring for kids that don't have those services already. So, just to reiterate, so TChat is a service that provides medication management, psychotherapy, counseling, and life coaching for free. And since whoever's in SAISD would have this opportunity to make use of these services. And if you're interested in these services, you could speak to your counselor to begin that referral process. Um, that's as much we have for Tea Chat today.